Welcome to Skin Injector Zone and Dissolve Those Fears. The content for this course will be what's your biggest fears, managing fears, dermal fillers and complications, VOVC, what to look for, necrosis, Hyaluronidase and reconstitution, elective reverse protocol, emergency reverse protocol, bruising, minimizing risks, hepatic infection, treatments. Introduction. For those of you who don't know me yet, my name's Tina McCaffrey and I am the CEO, Senior Lecturer, Assessor and Lead IQA of TTR, which is the parent company of Skin Injector Zone. I have been in the industry for over 25 years now and have extensive knowledge within aesthetics and beauty. I also work in my spare time with the SAS, which is short for Scottish Ambulance Service. I go out on 999 calls within the community. This means that you can be rest assured that the knowledge within all our courses is in depth and will allow you to be confident and competent in any treatment that you learn with us. We would like to thank you for choosing the Skin Injector Zone as your training app, and we hope that you enjoy the app and the course and any other courses that you take within the Skin Injector Zone. We always aim to provide full support, so please do feel free to ask us anything you are unsure about. Before you start, please read your manual and learn your theory. We also suggest you send a request to our online support group, facebook.com/groups/TTR Safe Space, where you will find all our other Skin Injector Zone practitioners, all of whom are very friendly, helpful and extremely supportive. So, what are your biggest fears? What scares you the most about aesthetics? How do you manage those fears? Who do you access for the support? Fears. There are many fears that you will have during your aesthetics journey. Vascular compromise, vascular occlusion, bruising, hematoma, eyebrow, eyelid droop, ptosis, not achieving customer expectations, but there are many other fears that you will come across in your aesthetics journey. This course is aimed at helping you alleviate those fears as far as we possibly can. Managing your fears. This is going to be one of the most important aspects of your aesthetics work if you come across a complication. What we want you to do is manage that fear. So stay calm. Being calm in front of your client when there's a complication is vital. It allows for you to look professional, and this transfers to the client. If clients pick up on fear from you, you will make them worse, and that will have a knock-on effect to you and then back to the client. So stay calm. Breathe. Just breathe. Breathe in through the nose and out through the mouth very slowly. This will calm your nerves, it will slow the heart rate down, and you won't panic the customer. Believe in yourself. Again, this is so important. You have the talent, you have the knowledge, and you have the ability. So if you remember these three things, if you ever come across a complication, stay calm, breathe, and believe in yourself. Anatomy. Do you really understand the anatomy? The best way to avoid complications of any kind is to truly understand the anatomy. Do you know where the facial arteries are? Do you know how many branches the facial arteries have and where these go? Do you know approximately how much fat is in the buccal fat pads? Do you know where the CNV11 nerve starts from and where it goes? So let's start with the facial artery. The facial artery comes off the external carotid artery and branches off from the mandible notch along the jaw, then goes up the cheeks where it starts to branch off in two directions. Under the lip, which is called the inferior labial, and over the lip, which is called the superior labial. It then continues up the face along the nasal labial and up the side of the nose, as can be seen in this picture. Did you know that there are many other smaller arteries which are located all over the face? Do you know where and what these are called? Study the image opposite and you'll be able to see where all the arteries are, how they branch off, and then they branch off into smaller arteries. Nerves, and are they important? Okay, so now let's discuss the nerves. Are they important? Yes, they certainly are. You ding a nerve when placing filler and that pain will be felt along part of or all along where that part of the nerve runs. Sometimes it can run right to the back to the palm of the brainstem. The facial nerve is the 7th cranial nerve, or simply CNV11. It emerges from the pons of the brainstem. It controls the muscles of facial expression and functions in the conveyance of taste sensations from the anterior 2/3 of the tongue. When you look at the picture opposite in this slide, you will see where the nerve branches off all around the face. So you can see that whilst the nerve is located quite deep within the facial structure, you could still ding it. You could still place filler, and that filler could compromise and push down on one of the nerve branches. So yes, it could happen, and if it did happen, it could cause quite a bit of pain. What we want you to do is study this slide. This is actually a cadaver head, and it shows you where the nerves branch off, and they're in yellow. So you can see where it goes up along the side of the face, along the cheeks, and up along the temple, and heading up towards the tear trough area. Nerve injury. So what are nerve injuries? There are 3 types of nerve injuries that we can cause. Neuropraxia. This is the least severe, so it involves dysfunction to the myelin layer of the nerve. Axonotmesis, as well as damage to the myelin layer, this also includes damage to the axon of the nerve. However, the endothelium is preserved, so the nerve will recover. Neurotmesis, this most significant damage to the nerve fibers. This type will vary, but eventually will lead to slow regrowth, or a poor and slow regrowth, or worse, permanent damage or loss of nerve function. Symptoms of and signs of nerve damage: pain, numbness, burning sensation, tingling and pricking, muscle twitching, paralysis, abnormal posture, bowel and bladder dysfunction, excessive or less sweating. Nerve injury. It is important that you confirm the diagnosis. We always advise that as a practitioner you get into the habit of using videos, as this will prove invaluable not only during the consultation but also in the future if there are further problems. So what we would advise you do is take a video of the client's face and get them to do facial movements such as smiling, pursing their lips, frowning, squinting, raising their eyebrows. Always ensure that you have carefully and fully documented these facial movements so that you can monitor the progress in detail. It's vital that you examine muscular function across the whole face. This includes the ocular and the periocular muscles. Always remember the facial nerve includes sensory and parasympathetic functions in its terminal branches. Always remember that it can be very difficult to be certain the nerve symptoms your patients report are because of the procedure that you carried out. So bear that in mind if this does ever happen to you, and ensure you have peer support structure in place so you have someone you can reach out to. If you need to, you can reach out to us either in our online community, on one of our social media channels, and if you need to get a hold of myself, then you can WhatsApp me and put urgent in your message. Now let's look at symptoms of nerve damage. In the case of neuropraxia, we expect symptoms to arise in a matter of hours, but not necessarily immediately. In the case of axonotmesis, you would expect a much more rapid onset of symptoms as the axon itself has been damaged. Neurotmesis will occur immediately as much of the nerve has been severed. Another important sign to look out for are the signs of infection more consistent with classical Bell's palsy. Finally, nerve injuries, although rare, they can be a very important side effect. So please always remember where the nerves are and how they can be damaged. Salivary gland complications. Please take a look at this slide and the image where it gives you the various glands, ducts, and where they're located. Inflammatory and non-inflammatory lesions. So what are non-inflammatory lesions? Simply put, they are a lump or a bump of isolated filler or fluid under the skin, which is generally not painful, but usually cosmetically unappealing. Non-inflammatory lesions are probably the most common adverse side effect you will see as an aesthetic practitioner when you're performing your dermal filler treatment, aside from bruising that's common in the lips. So what are you looking for? Well, you are looking for a soft, spongy lump which demonstrates fullness or edema, in other words, swelling, in the area where you previously injected. Yes, it is common, but they are also the simplest to manage as there is no biochemical reaction going on between the filler product and the body. Usually, simple massage techniques will solve non-inflammatory lesions. It is important as a practitioner that you remember this can have a huge impact on your client, and they may well be very worrying for them. This can mean they will be in touch with you a lot, and it can be very stressful for you as well as them. Small lumps that are not visible can be left untreated and usually resolve on their own. Yet a more visible and obvious lump can be awful for the patient. If this happens, it can mean that you need to take a more aggressive approach to sort it out, which you may not otherwise have done. It is important at this point to note that if the lump or bump shows signs of inflammation, such as redness or tenderness to the touch, then you are now dealing with an inflammatory lesion caused by a foreign body or allergic reaction, which does require a different approach. It is vital that you properly investigate and diagnose lumps caused by dermal fillers and are able to distinguish between non-inflammatory and inflammatory lesions. Inflammatory lesions or nodules are a serious possibility when it comes to dermal filler complications, and much more than non-inflammatory lesions. So what causes inflammatory lesions? These can be caused by so many different mechanisms, all of which can present in various ways and need to be managed in different ways and need to be investigated correctly. It may be post-procedural inflammation, viral reaction, hypersensitivity reaction. Symptoms will vary with each client, so it's important to learn how to diagnose the inflammatory lesions, but ideally having the knowledge and skills to prevent them from occurring in the first place. Hypersensitivity, this is a very rare complication, but can happen and is usually rapid and serious. This happens a lot within immunosuppressed clients or clients with systemic illness. Bacterial complications. Bacterial infection, what is it? We know bacterial infections can happen after dermal filler procedures, although they are rare. Why? Because we all take simple preventative measures, which means we can usually avoid them happening. All bacterial infections can be categorized into different levels of severity. The easiest one is what we call a transient inflammation of the area, which persists and then will eventually resolve as the body fights off the bacteria. More serious problems come with reactions such as biofilm or abscess formation. Septicemia, of course, which is most threatening to life. Bacterial infection cases reported in relation to dermal fillers have been caused by external bacteria entering the skin. This means it is vital as an aesthetic practitioner we always use aseptic techniques and clean the skin before injecting, as well as using sterile equipment in a well disinfected clinical environment. Okay, so let's deal with salivary gland injuries. The chin and jawline contouring with dermal filler treatments has become very popular over the past couple of years and has led to an increase in salivary gland injuries, particularly as these are usually performed with a cannula. Many practitioners believe that the use of cannula is ultimately safe, But as with anything, no technique is ever 100% safe. Remember, a cannula has a blunt tip and is there to push arteries, nerves, veins out of the way. But what a cannula can do is, as it's entering, it can rip through and risk tearing the tissue and the glands. This type of injury can be extremely difficult to spot. Therefore, it is vital to understand how you can diagnose a salivary gland injury. This is because they have similar symptoms to inflammatory lesions. Salivary gland injuries can be broken down into two main areas: equipment used in the procedure. Salivary gland injury is typically caused by the use of a cannula. The jawline and chin is usually treated as a cannula only area by many practitioners. Cannulas can cause this injury as they often expose structures to a lot of shearing force as they are pushed through the tissue layers. As you can see from this slide, there is a lot within the anatomical region where the glands are, and this means that the passage of the instrument should be in the hypodermic fat and nowhere else. This lies directly adjacent to the layer of fascia covering the surface of the gland. So you can see why it is so vulnerable and how an instrument such as a cannula will penetrate if it's a little too deep. With severe injuries in this area, it can also be possible for you to damage the duct and the branches of the facial nerve which pass through this gland. These structures, whilst much deeper within the gland, as an experienced injector, you should know you are in the wrong place when you go too deep. An experienced injector will be able to tell by the feel of the needle if they are in the wrong place. If you're not quite experienced at the moment, what would be a good idea would be for you to feel the needle. So as you're going in, listen to what the needle is telling you as it passes through the various structures of the face. Vascular occlusions and compromises. Early recognition, timing and treatment is extremely important to limiting any damage to a client's tissues in the event of a vascular compromise or a vascular occlusion. Now, when we look at this slide, we can see in the slide where the lip is bruised, where there appears to be some whiteness and possible blanching. There's a spot more towards the center of the lip. Now, many injectors, especially if they're not experienced, will see this and panic. They will assume that they have caused an occlusion or a compromise. One of the things we advise you not to do, or we strongly advise you not to do, and that's don't take pictures and put them on social media groups, because you will get ripped to pieces by other practitioners and everybody will be going, oh, it's an occlusion, oh, it's a compromise, you need to dissolve it. This photo you're looking at is simply a bruise. It is not an occlusion, it is not a compromise. The more experienced you get, the more you'll be able to spot what's going on. With this, all that needs to be done is simple massage. So in this picture, we can see where filler has been placed. Now, when we look at it, there seems to be an awful lot of blanching. For example, if we take a look at the bottom lip, the middle towards the vermilion border on the bottom lip has a white patch. If we look at the top lip in the vermilion, we have a white patch, and if we look towards the vermilion border, we can see a white patch or blanching. So most practitioners would look at that and go, oh, that's definitely an occlusion. Again, this is not an occlusion. It is simply where straight off the needle, filler has been placed in and it has slightly compromised the lips. All that needs to be done with this is massage. So you take the lips, you massage them, and then you will bring back the pinkness. All you're doing is moving the filler, smoothing it out so that the blanching disappears. That's all you need to do. Okay, so what about this one? In this photo, you can see that there appear to be lumps either side of the bottom lip. This is not a compromise, it is not an occlusion, there is no blanching, it is simply filler. All that needs to be done here is a warm compress and massaged. If this is a few months old and you had a client come to you with this and they say been elsewhere to another practitioner, you would find this quite hard to massage out, and if you were able to do it, you'd have to do quite a vicious massage on the 2 lumps. So this would maybe need to be popped out, so you would use a 21G needle and push the filler out. If that didn't resolve it, then you probably need to dissolve before you did a treatment. So what's wrong here? This is actually a very interesting case. This was a practitioner who did a treatment on herself, and while she hadn't been trained by us, she was in our online community and did contact us. And what she had done is placed dermal filler between the nose and the cheekbone. And whilst it hadn't caused an occlusion, it had compromised the artery and was sitting on the facial nerve in that area. So it started to become inflamed, sore, and the redness, the erythema, started to travel all the way down the face, as you can see in this first photo. The second photo is a close-up of the area where she injected the filler. What she did before contacting us was she used a dissolver in the area, but she didn't just use it in the cheek area where the filler was. She also injected around the nose, down along the nasolabial, the marionettes, and around the chin area. That's an awful lot of hyaluronidase to use, especially as the filler was only located in a small area and she injected much further along. This did sort itself out. She did have some bruising. It did last 2-3 days. We kept in close contact with this practitioner for 3 or 4 days to make sure everything was okay, advised her along the way and helped to keep her calm during the settling process. But you can see just how treatments can go wrong. Luckily in this case, this didn't go drastically wrong. It was just a compromise which was sorted. Okay, so these 2 photos are the lips that we were discussing earlier. You can see in the first one the blanching. The previous photo that we looked at with the lips was taken from the opposite side. This one is taken from the other side to give you a different view of the lips and the blanching. The second photo are the same lips, but this time we've taken a look underneath. So we've lifted the upper lip up and you can see the trauma underneath. This is caused by bad technique and bad training. Okay, so when you're looking at injecting, it's all about technique. It's all about the gentleness of your technique. Your technique should be so it should be 45-degree, bevel in, level bevel, slide in. So as you're doing it, you're going in fast but smooth, and you're pulling out very slowly when you inject. Please take a few minutes to study this slide and where the labial artery is located and how it branches off. Again, please take a few minutes to study this photo. You can see where the superior labial artery branches off into the lip. The cross-section of the lip. This is a really interesting slide to look at, so take a few minutes to study it. It's an important part of lip anatomy. It's the cross-section of the lip. It's a histological specimen cut lengthways. We can see the artery here runs inferior in the orbicularis oris. That's usually 65% in most clients. What's the risk with vertical versus horizontal injection? The riskiest injection is the one where the needle is likely to deposit the most amount of filler nearest the artery. So, is that vertically or horizontally? This question actually divides practitioners across the industry. What is the likely anatomy of the labial artery in the average client? First, no client is the same. So remember, we always tell you that each client, although anatomy and physiology is the same, We're all unique. So it's important to understand that we will never truly know 100% of the time where it is. It's important to understand that we are not discussing the amount of injections, but the angle of the injection. Vertical versus horizontal. Take a few minutes to study these slides. As you can see, horizontal, vertical. So you can see what we mean when we say where we're going in the lip. The percentage ratio. Usually, the labial artery in most clients runs underneath the orbicularis oris. Approximately 65% of your clients fall into this category. Running within the orbicularis, 35% will fall in that category. Running above the orbicularis oris, 5%. In some people, we can have an anomaly called decalibre persistent artery, which will actually be located in the wet, dry lip border and can be seen pulsing. This is around 2 to 3% of your clients. Did you know that in the older, mature lips, the arteries will actually take up more space? So when you're dealing with the older, more mature client, please bear in mind that the lips lose volume, and as they lose volume, so the artery will take up more space. So of course, there's going to be more risk, danger of a complication. The older lip. As we said, the older person naturally loses volume and the lips become smaller and involute. In some cases, the lip looks as if it has disappeared and you get atrophy of the border. So a vertical injection in very small lips or older lips may mean more danger as you are dangerously near the artery. Volume loss and arteries. It's worth bearing in mind that the same applies to the whole face. We lose volume across the face as we get older. This means that the arteries will take up more of the face as the volume decreases. So when working with an older client, please bear in mind the above and what we have just been discussing. Next up, rhinoplasty and BOs. Do you know what complications to look for when doing rhinoplasty? This is vital for anyone doing dermal fillers in this area, as it can very, very quickly turn nasty. The tip. It's important to understand the filler and the nose, as this is an extremely high risk area. There are 3 high risks to this area: blindness, septal injuries, most important, stage 1 pressure ulcer forming. Please take a moment to study the photo in this slide. Capillaries. There are actually no arteries in the nose tip, but as you can see from the picture, there are a lot of capillaries. Blood pressure in arteries is 180/80, but far less once it arrives in the capillaries. So this means there is far less pressure in the capillaries, which means it takes far less pressure to affect the capillary vessels. Also, there is far less space in the nose area, thereby possibly increasing risk. Injecting the nose. It's important to really think about how you are injecting and the amount you are injecting into the space that's actually available. How much pressure difference are you making in that area, as this can be the difference between a successful result and the start of necrosis. If you have caused pressure in this area, it will usually be red and constant with pain, so the tip will be red and fades as it goes laterally. Necrosis of the nose tip. Take a few minutes to study this slide and the image that's in it. Whilst it's not a nice image to look at, it's one that you really should bear in mind, because if you're doing rhinoplasty and you are doing things such as the Tinkerbell tip for someone, this can happen. And if you've got this visual in mind, you'll be very aware as you're injecting, and you'll pay attention to how much filler you're injecting into such a small area. Pressure sore from fillers. Where else can we get pressure sores? It can sometimes be seen in the glabella. On most fillers, it is contraindicated to use in this area. If it did happen in this area, then it would be more than likely because it's compressing the artery and or capillaries in the papillary dermis layer. It will be very localized, and there will be a line where the filler was, and will be red in that area with possible onset of necrosis. High risk factors. The lower third of the nose is more high risk, injecting any area that is tight, i.e. the tip of the nose. High volume injections over 0.5 ml. Think about the force of volume in an area, especially the tighter, more compact areas such as the nose. Hypertension. This can cause rarefication, i.e. there will be fewer capillaries, so possibly greater risk. What other VOs are there? Do you know them? Point occlusion. This is where we have one small area becoming blocked. Comprehensive occlusion. This is where we block one area in artery, but then as we continue, it starts blocking other arterial areas. So for example, from the superior artery, it then starts blocking the columella branch, but it is also all the other smaller arteries that can become blocked as well. In other words, you have blocked off not just that artery, but all the other smaller arteries, causing a cascade effect. Spotting the above is usually easier than any other VO and can take more time to show. Small area of discoloration, then you see it develop over time. For example, it can go up into the supratrochlear artery, and that whole network of blood vessels is then affected, especially when using bolus and larger injection techniques. Anastomosis. This is simply a connection of two branches. It's the infraorbital artery or the facial artery or the superior labial artery. For example, filler blindness occurring because of the temple artery, which has connections to the supratrochlear artery. You also have fragmenting filler. This is when you're dissolving filler and it breaks up into different sections. So potentially you have the issue of fragmented filler being able to enter a different area, such as in the anastomosis. So even though you've been dissolving and massaging, there is still an issue of an occlusion that you may not be aware of because you fragmented the filler and a tiny bit of that filler has now moved and blocked somewhere else. So what can we do to protect our clients, especially in the nose area? Always get into the habit of feeling the client's nose before you even start looking at injecting. Feel the actual layout of the nose and the tip. Does it feel tight or not? Does it move easily? Is there space? The tissue moves easily and the nose is mobile. Always inject small amounts and keep checking the area. If you want to lift the tip, try and do it with your fingers first at the side of the nose. This is always a good indicator as to whether it can be successfully done. Always assess cap refill throughout the process. I always check the nose around 20 times, sometimes probably more when I'm doing nose work. I like to be safe, and so should you. In this slide, you can see the Tinkerbell nose tip. This was very successful and was done very carefully, checking the nose area before we even looked at injecting. Rhinoplasty correction. In these two slides, you can see in the first photo where the client had a slight ridge, and afterwards where we corrected it. Now, this was a client who a few years previously had broken the nose, had it reset, then it broken again, had it reset, and then unfortunately for her, she was playing with her son and a soft ball hit the nose, but because the nose was now quite fragile after the two surgeries, it happened to split again, and the surgeon was unwilling to attempt this again as it was highly unlikely to be successful, so he referred her to us for the filler procedure. This procedure was not carried out in one go. This procedure was carried out very carefully over 2 sessions. What we did was we checked the nose, we checked the gap, we injected very slowly from the side and from the top, and we made sure that as we were doing it, we were checking our cap refill, we were checking the area, we were ensuring that there was no signs of blanching or pain, etc. And the end result was perfect rhinoplasty correction. What to look for, the signs and symptoms. Pain. This may actually be absent initially due to the local anaesthetic effect, because all filler, or most fillers, have a small percentage of lidocaine in them, so this will actually cause a numbing effect, so therefore your client won't feel any pain at all until the anaesthetic starts to wear off. Pallor and blanching. Blanching of skin may occur immediately after intra-arterial injection as a temporary phase. Slow cap refill. Digital compression of affected area shows slow blood return. Return of normal pink colour after 1 or 2 seconds is considered normal. Slow capillary refill may be a sign of arterial insufficiency. Blue or grey blue. This is where you have local tissue oxygen depletion. The deep blue of deoxygenated blood will be predominant. So what do you notice about this image? Take a few minutes and study the slide. It should actually be obvious to you at this point where the blanching is. So the blanching is where we've placed the arrows, and the client has probably had filler placed just next to the nostril at the top, between the nostril and the top of the nasolabial fold. So bolus has probably been put in there. But what's probably happened is the bolus has been placed a bit too close to the nasolabial fold, and this has caused some of the filler to migrate to the other side of the nasolabial fold, and that's why we now see so much blanching in the nasolabial area around the top of the orbicularis oris and going up the nose into the orbital area. So with this, action would need to be taken very quickly to dissolve, to stop any further complications arising, such as tissue, oxygen, etc., depleting in that area, causing necrosis. Okay, so in this picture we can see that there's blanching going on, blanching around the vermilion border just underneath on the chin, and we can also see blanching going into the vermilion on the bottom lip, as well as quite severe bruising. Now when we look further along, we can see that the blanching is heading towards the side of the vermilion as well. So what we would look to do with this particular client would be cap refill, and the cap refill would be done on each section of the lip, middle and sides. We would look to have the cap refill in under 4 seconds. If it's not under 4 seconds and it's above, between say 5 and 7, then we would look to massage the area gently but firmly, and then do further cap refill again on the middle and the sides of the lip. If that still didn't work, then you would probably be looking at dissolving. If you did cap refill on the middle and the sides and you found that the cap refill was very sluggish and slow, above 7, between 7 and 12 seconds, then you're going to look at dissolving. So we would need to have very detailed look at what was going on with the lip, not just on the outside but on the inside. Once we've done all this and we've videoed the cap refill, so always remember, when you are doing any kind of complication work, you need to have a video of the cap refill, pictures of the lip before, during and after the session. Now if it came to dissolving this particular issue, what we would look to do is reconstitute our Hyaluronidase, and you will see the Hyaluronidase video on how to reconstitute. You always treat to effect. So what we mean by that is we would inject less than a unit into where the filler feels hardest, and we would massage, start breaking it down, then inject a little bit more, and then massage again, inject a little bit more. We would do this, and it could take us an hour, 2 hours. We may even need to have to bring the client back the following day. So dissolving in a case like this wouldn't just be a 20-minute quick session. This has to be done gradually, very slowly, making sure that you know what the reaction is with the filler and how it's dissolving. Once you've done all this, you will also do your cap refill to see how it's. You should by then see that the lip is going back to being pink, and the blanching that's happening underneath the lip and the redness will start to fade. Once we've done all this, we will then make sure that the cap refill is good, under 4 seconds, and we will keep our client with us for a good half hour to 45 minutes to make sure that she's not going to have any reactions. If we do need to bring this client back the following day, then that's what we do. We book them in for an appointment and we see them the following day. If we don't need to, then we call them the next day and ask them for an update and to send us some pictures of their lip. Please remember also to explain to your client that it may feel rather sore and tender for the next few hours. And what I would also advise is that you tell your client that due to Hyaluronidase and its properties, you will not be able to put any further filler into the lips for at least 3 weeks. That way the Hyaluronidase has had a chance to dissipate and you can fill the lip safely, knowing that the Hyaluronidase is no longer going to dissolve any filler that you may put in. Necrosis. Now this is the one that many practitioners fear the most, because it is such a nasty issue to deal with if it's not been caught in time. Necrosis is one of the most severe and feared early occurring complications in aesthetic treatments and may be due to interruption of the vascular supply, compression of the area around a vessel, obstruction of a vessel with foreign material, direct tissue damage due to physical, chemical, radiation or laser properties. The incidence rate is estimated to be 1 in 100,000. In this slide, we've put some photos on to show what the necrosis looks like as it starts to bite, and the second photo shows necrosis in its later stages. So you can see it's not nice, it's very sore and very red in the first photo, and you can see how it's become infected and the tissue is starting to die. In the second photo, this is severe. The necrosis has really set in, the skin is turning black, and she'll be undergoing a lot of treatments, and there's very much the possibility that surgery will be involved. If surgery occurs with necrosis, they don't just take the affected area, they leave a wide margin. So in the nose area they would go a good 1/4 of an inch all the way around. So you know they would do surgery and end up taking quite a bit of the cheek area either side to ensure that they've got all the necrosis. Necrosis of the lips. The following slides show necrosis of the lip. These are upsetting photos but important so you can see the potential damage if you do not follow up. Dr. Ala Arif from Renew Clinics in Saudi Arabia is showing a patient suffering from necrosis which ultimately resulted in the loss of part of a lip. Dr. Arif came into contact with this patient, and whilst unable to save the lip entirely, we can see that the results are excellent given the seriousness of this particular necrosis. So these are the photos of the lip necrosis, and we can see that on the 25th of the 1st 2019 the bottom lip was black. Necrosis had set in and there was no recovery from that, so this required surgical removal of the lip. So on the 26th of the 1st you can see where they've started taking away the lip. On the 2nd of the 2nd the lip affected area has been removed, and then on the 5th of the 2nd we can see how it started to heal. So these are the final results of the lip necrosis, and we can see from the first photo to the end photo that the results are really good. The Dr. Arif, who did the surgery to remove the necrosis, has done an excellent job, managed to save the rest of the lip, and you know the end result being that she's got some scarring and loss of volume, but nothing compared to what it could have been. These are rare and it's not going to happen to the majority of practitioners. This would be the result of the necrosis not being picked up in time, the complications at the very beginning where it was showing blanching, bruising, blue, grey colour, that would have all been missed for it to get to this point. What's another word for aspiration? I'll give you a couple of seconds to think about it. Another word for aspiration in layman's terms is called flashback. Now, when we're doing aspiration, we're going to put the bevel in, level bevel, slide the needle in to the area that we're going to inject. Then what we're going to do is we're going to pull on the plunger, and it's at this point that you have to be very careful how you do your aspiration. So as the needle goes in and you pull the plunger back, you need to make sure that your needle does not move out. If the needle moves out, when you push the needle back in, which is what you're going to do, you're now going to be in a different area to what you were when you first did the aspiration and pulled on the plunger. So it is vital that when you do aspiration, you go bevel in, level bevel, slide the needle in, and you keep the needle in. It shouldn't move at all. Hold for between 5 to 10 seconds. It's not going to make any difference to your client whether it's 5 seconds, whether it's 10 seconds. They're not going to know the difference, okay? But please remember that the bevel on the needle is really, really tiny and blood is quite thick, so it can take a while for it to head up into the needle. You can see in the picture here, that's a positive aspiration, so we've got positive flashback. If you get positive flashback, remove the needle and take the needle off, put a new one on, as long as the blood hasn't gone up into the syringe, and then you can reinsert. Aspiration or flashback. For clarification, within the industry, it is a rather hot topic whether to aspirate or not. What do you think? What are your views on aspiration flashback? Many practitioners are told to aspirate for around 5 to 10 seconds. Here at TTR, at Skin Injector Zone, we advise anywhere up to 20 seconds. Can you think why? The reason we advise up to 20 seconds, it depends on the area that you're in and how much filler you're going to be placing. So, you know, as I said earlier in the previous slide, 10-20 seconds, the client's not going to know because it goes real quick, but at least you are certain when you're doing a long aspiration that you are in the correct area. Some practitioners are taught not to bother aspirating when doing the lips. What do you think? Now remember, go back to your anatomy of the lips. You know that the arteries branch off into the lips. So would you or wouldn't you? And again, it goes back to, you know, if you're doing vertical or horizontal when you're doing an injection technique, again, you might just hit the tip of the artery branch. So I would always advise that you do aspirate. Okay, so in this photo, we can actually see blanching, pure white, and we know that there's an occlusion going on here. So we're going to do our cap refill along the lip area and check to see if it actually goes white in and around that area. If we're still unsure, then what we can do is use a needle and pinprick right at the very edge of the blanching. And if we get blood, then we know that there is still blood getting to the area around where it's blanched. So what we would then do is warm it with a compress, warm compress, and then do firm massage to see if that helps to resolve the issue. If it doesn't and it still stays white, then we would look to dissolve using the treat to effect technique. What to do next in circumstances like this? So what should you do if you think there's a problem? It's important that you stay calm. Remember, breathe, relax, and believe in yourself. Staying calm will reassure the client, because if you panic in any form, you will start to worry the client and this will make the situation worse. If it has happened during the treatment, then the first thing you need to do is your cap refill. You should have been doing your cap refill all through the treatment and videoing your cap refill at least once. A safe cap refill should be under 4 seconds. If it's above 4 seconds, 5, 6 or 7, then there is a possible compromise. Longer than that, and it's more than likely a compromise or an occlusion. If you have a white patch, similar to what you've seen in the previous slide, another way to check it, as we said, is to pinprick it with a needle. And if there is blood next to the white patch, then you have still got blood getting to the area. Remember, if this type of complication shows itself when you're doing the treatment, you have time. Okay, there's no panic. You can do the treatment, you can dissolve if you need to, and you have the safety time. If it happens when the client's left and they call you the next day or the day after, then you get them to come in so that you can assess the situation, do your cap refill, refer back to the cap refill video that you did whilst you were doing the treatment, and then you can decide what you're going to do next. We're just going to refer you back with this slide to the white patch so that you can see the white patch again, and you can see that the area has been pricked with a needle to see if the blood is getting there, and it is. In this slide, we've added a video of a practitioner doing a video of cap refill. Please remember that when you're doing cap refill on your clients, you would be wearing gloves. Before dissolving, capillary refill. If you notice blanching, the first thing to do is to check your capillary refill. If this stays white and refill is slow, then you need to do the following before dissolving. Don't just go, oh, I need to dissolve, I need to dissolve. No, you do a couple of other things first. Massage the area firmly for a few minutes. Then check your capillary refill again. It should now refill and go pink immediately. If it doesn't, then you massage again and you repeat this process. Dissolving should always be your last option. Other signs of complications. Vascular compromise as a result of hyaluronic acid filler injection should be treated immediately. Any signs of impending necrosis include pain, prolonged blanching, reticulated white or dusky appearance of the skin, and coolness of the skin. Hyaluronidase should be administered as soon as these complications occur. There is good evidence that tissue necrosis will be prevented or be less severe the sooner the hyaluronidase is injected. The Tyndall Effect refers to the scattering of light that may be seen in some patients after injection of hyaluronic acid, resulting in a bluish hue to the skin. It's often caused by practitioners injecting too superficially or placing large boluses of product in one area, or using an inappropriate product for the area they are treating. It is most commonly seen in the subocular region. By degrading the hyaluronic acid and using hyaluronidase, this problem can usually be corrected. In this slide, we're going to talk about patch testing. It is vital before dissolving that you do a patch test, as reactions can happen. Some can even happen hours later. However, if an emergency, a patch test is not required. So we can see in these two photos here that a patch test was done, and 6 hours post-patch you can see that there has been a slight reaction. 7 hours in the second photo, you can see that there's actually been quite a large reaction. The area that was injected, you can see, is slightly raised towards the top of the photo, and then we've got erythema, redness of the skin. It is important to note here the following: elective procedure equals patch test, emergency procedure equals no patch test, and a possible procedure equals a patch test. So what do we mean by possible procedure? This is where there is a possible compromise, but you as the practitioner have time to correct it. If this is the case, then you do a patch test and wait a minimum of 45 minutes to an hour. Always, when you're patch testing, ensure your first aid equipment in the clinic in case of the client having a reaction. If you're doing a procedure, say a client comes to you, they've been elsewhere and a practitioner's done their lips and they don't like them, they want them dissolved, that's called an elective procedure. We would, however, recommend that you do not dissolve another practitioner's work, at least not until you're very competent and confident in what you're doing. Hyaluronidase. It's an enzyme used off-label. The UK version is of sheep ovine. Store in the fridge between 2 to 8 degrees. Use and then discard any that's left over. A bit about hyaluronidase. What we want you to do is read this slide. So take a few minutes, read through this slide, and then move on to the next slide. Off-label. Although hyaluronidase is not licensed for the use in correcting problems with dermal filler injections, and off-label promotion is not allowed by Article 87 of Directive 2001/83/EC, its use is allowed provided the patient's best interest and autonomy are respected and it forms part of the informed consent. Reconstitution and administration. Reconstitution of hyaluronidase. Please take a few minutes to watch this video and play it back if you need to. In the video you can see we have set up the trolley with a kidney dish, we have our syringes, we have a 21G drawing up needle, we have the 27G needle, we have alco wipes, we have our Torbac, and we have the hyaluronidase. So what we will do is we will break the vial of the hyaluronidase and we will put the 21 gauge needle onto our syringe. Once we've done this, we then break the cap off the Torbac vial and we draw up, using the 21 gauge needle, 1 ml of the Torbac solution. We then insert the Torbac into the hyaluronidase, and as we're inserting it into the hyaluronidase, we're going to use the product and swirl it around the vial to ensure that any hyaluronidase powder is taken off the sides of the vial. Once we've done that and we're sure, we're going to then draw the hyaluronidase back up into the syringe and then push it back down into the hyaluronidase bottle. We would repeat this process at least 2 more times. Once we've done that, we can then draw up the product and we are ready to dissolve. Now remember, when we're dissolving, we are doing it treat to effect. So we're not going to just throw in lots of hyaluronidase all over the place. We're going to go in very gently. We're going to use less than a unit. We're going to massage, then we're going to use a little bit more, then we're going to massage, and you could find that this could take you an hour, 2 hours, or depending on how much filler that you have to dissolve, a lot longer. In this video, we are doing the patch test. So we've already reconstituted the hyaluronidase and we're going to patch test. The way to do that is to put a circle on the area that you're going to patch test, and then you're going to inject some of the hyaluronidase into the area. The reason you leave a circle is to make sure that you can see if there's a reaction, how far that reaction is spreading. Reconstitution instructions. You can open a 10 ml or a 5 ml ampule of your Torbac, and you add 1 ml of the saline to the opened ampule of hyalase or hyaluronidase. Ensure the powder is fully dissolved. Draw this up and expel the syringe a couple of times back into the hyaluronidase bottle to ensure complete mixing. So in other words, you will aspirate the 1 ml of saline with the reconstituted hyalase and reintroduce it then into the ampule of saline, the 5 ml or the 10 ml of Torbac. Agitate the ampule to ensure the hyalase is mixed thoroughly throughout the whole volume of the saline Torbac. This now gives a concentration of 150 units/ml. The reconstituted solution can now be drawn up in a 0.3 ml or a 0.5 ml syringe with either a 27G or a 30G needle. Each 0.01 ml graduation represents 1.5 units of hyalase. Hyalase may be reconstituted with either saline, your Torbac, or water, sterile water, for injection. However, please note, if you're using sterilised water, that will sting a lot more than if you're using Torbac. Reconstitution with saline tends to produce less stinging, so it is recommended. Although local anaesthetics may be used to reconstitute the product if you're trained to do so. Amounts to inject. It is recommended that you treat to effect rather than to absolute dosage, injecting as much hyaluronidase as required to obtain the desired effect. However, The table below will give an indication of how much will be required. Nasal and perioral skin 15 to 30, periorbital 30, infraorbital 10 to 15, lower lid 1.5. How to inject. Prior to injection, the area should be inspected and palpated and marked out if needed. The area should be sterilised using an appropriate skin solution, and the procedure should be carried out using as close to aseptic technique as is possible. A 27G or 30G needle with an appropriate length to treat the depth of the area should be used. Administration should be extremely accurate and limited to the affected area only. In case of nodules, they should be injected directly, and for product that has been injected into superficial dermis, injection should be placed immediately into and below the product. For vascular compromise, serial puncture should be used to inject the hyaluronidase along the course of the vessel. The needle should be perpendicular to the skin, and several injections are often necessary. During and after the procedure, the treated area should be massaged rather vigorously to optimize the result and aid mechanical breakdown. Results are often seen almost immediately, although for denser, more cross-linked products it may take 48 hours for the effects to be seen. A review appointment at 2 to 3 weeks should be offered, and further treatment offered at this point if it's needed. Following administration of hyaluronidase, the patient should be observed for a minimum of 30 minutes to ensure no adverse reactions occur and aftercare given. In the event of any delayed reaction to the treatment, the patient should be seen at the earliest opportunity. Complications to hyaluronidase. Please take a few minutes to read through this slide to make sure that you have memorized it. If you need to refer back to it, then please do so. Other medications. Please take a couple of moments to read through this slide and the drug interactions that can affect hyaluronidase. This is by no means an exhaustive list, and there are other medications that can interact with hyaluronidase. Minimizing the risks of any adverse reactions. No alcohol 24 hours prior to the procedure. Vitamin C and iron deficiency increases risks of bruising. Medications such as aspirin, etc. Do not stop these. Let the client continue to take them. Arnica cream afterwards can often help with bruising and minimizing it. And another one that they can try is pineapple, fresh pineapple. Infections. These will be bacterial or viral. They're rare, presenting within 3 to 7 days normally, and will show up as red, hot and inflamed. Prevention. These would all be standard. Clean area prior to injection using alco wipes. Remove makeup. Ensure that you're doing hand hygiene in the aseptic non-touch technique. Ensure that your trolley is sterile, the equipment that you're using is sterile, and that any packaging is not broken or ripped. If it is, then it has to be thrown away because it is now contaminated. If there was any bacterial or viral infection, then you would work with your prescriber, and your prescriber would issue a prescription for medication. Review after 48 hours, and remember to take photographs. Hepatic infection. Incident rate 70% for HSV-T1, 10% for HSV-T2. One of the commonest issues that your clients will get with regards to dermal filler are cold sores, which is a part of the herpes family virus. So as you can see in this photo, this is a cold sore that's actually healed. What we would advise that you do with regards to this is it must be asked on your consultation form. Does the client suffer from cold sores? Even just one cold sore 20 years ago, they still have the herpes virus. So although it's not active and they've only had one in their life, having filler can actually activate the herpes virus and they will get a cold sore. Well, some can get cold sores. So it is vital that you know whether they've had a cold sore, and you explain to them that if they have even so much have one cold sore in their life, then they do have the herpes virus, and they either need to go to the GP and get a prescription and take that 5 days prior to seeing you, or they use some Zavirax and they place that on the area for a few days leading up to the appointment with you. If they do suffer from cold sore viruses, make sure that they know to have some Zavirax kept in their handbag or in the house, so that when they feel that tingling, they put the Zavirax on and they stop that cold sore from erupting. Because once that cold sore erupts, it can chase the filler around the lip, and so that they could end up with more than one cold sore. Now, sometimes you'll get a client come to you who's had previous filler before, and they've got a little lump of filler, either just inside the mouth or just at the edge of the vermilion. If that is the case, you can try massaging very vigorously, rule out infection, and you can do what we say is pop and squeeze. So you get a 21G needle, you insert that needle, create a hole, and then you pop and squeeze that little filler lump out. Work with prescriber and consider antibiotic treatment added in if necessary. Treatment if a reaction was to occur. Stop treatment immediately, lie them face up, and call 999. DONS, delayed onset nodules. They're visible or palpable unintended mass which occurs at or close to the injection site of dermal filler. Instant rate of this is between 0.6 to 0.8%. and will usually occur in immune reactive clients. Okay, anti-wrinkle, in other words, botulinum toxin. What can be done if you get it wrong? There are some things that you can do that maybe lessen the effect, but usually it's only time that will sort it out. Ptosis, droop or abnormal lowering, typical to the eyebrow and eyelid region. Eyebrow ptosis, so we can see here where the eyebrow has started to droop slightly. You will avoid brow ptosis by injecting at least 2 centimeters above the brow, or if it's an older client, 4 centimeters, because the older the client, the less strength the muscles have, and their skin's already and the muscles already started to droop anyway, so you'd want to avoid that by going 4 centimeters instead of 2. Always be cautious in clients following surgery. And here we can see a really good example of eyelid ptosis. If you were to cause ptosis of the eyebrow, then these 2 injection sites would help to possibly lift it, although this isn't guaranteed, but it might have some effect. Another way to avoid ptosis is to remain 1 centimeter above the brow when you're treating the glabellar region. One of the other things that you can do if you were to cause ptosis, and that's, some people say, use an electric toothbrush to try and stimulate the muscle. It might work, but not likely. And the other thing you can do is get the GP or your prescriber to issue some eye drops, which would be used 1 or 2 drops 3 times per day. Always, and I can't stress this enough, manage your client's expectations. It's tricky, but the golden rule here is you don't promise anything. We've all been there, we've all had, as we've said previously, we've all had that client that walks in, you ask them what their expectations are, what they're looking to achieve, and they come out with a photo of some famous actress, and you look at the photo and you look at them and you're like, No chance, that's not happening. You have to manage these expectations. You have to say to them, well, obviously this person has had X, Y, Z, we've got to do some work to get to that sort of result, and it will require 3, 4, 5, 6 sessions over a period of a few months. So manage their expectations, and please never promise them anything.
Welcome to TTR, home of the elite skin injectors. This video is to show you how to perform CPR on somebody who has had cardiac arrest using the COVID-19 way. Whereas before, when somebody was having cardiac arrest, we would go down and we would tap on the shoulders, we would shout, "Can you hear me? Can you hear me?" And then we can't, so we would shout in both ears, "Can you hear me?" That's because they could be deaf in one ear. Then we would put our ear to their mouth, check to see if their chest is rising. We can't find any signs of life, so we locate the tiny bone in the centre of the rib cage and we go 2 fingers above. And then we would start our CPR, which would be 30 compressions. 1, 2, 3, 4, 5, 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Then somebody would come with a defib if you haven't already got one, and you would place your pad there and there. It would analyse and advise if a shock was required or not. If not, you would continue with your CPR until the ambulance arrived. However, now, because of COVID, we don't do that. Now, we don't do that because if the client, or if the patient is in full cardiac arrest and they had a last agonal breath, which is the last breath leaving the body, all the droplets and the breath will hit you full in the face. So what we do now is we stand and we say, "Can you hear me? Can you hear me?" And we're watching to see if there are any signs of movement. There are no signs of movement, so we would go down, we would get our defib, which we would place. So we've taken the shirt off, we place one pad here, and we place the other pad here, nice and firm. We turn our machine on, and once the machine is on, it will analyse and it will tell us whether we need to deliver a shock or whether we need to continue with CPR. It said we need to continue with CPR. Now, the reason I've not put the actual defib on is because it's a real defib and it won't recognise the dummy, so it will just keep saying apply the pads. It's telling me that I need to deliver CPR, so I'm going to locate the triangular bone in the centre of the rib cage, lock my hands together and my arms, and 2 fingers above that triangular bone. This time, instead of 30 compressions, I'm delivering 120 to 240 compressions over 2 minutes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Now I continue 120 per minute for 2 minutes, so that's 240 compressions that I will deliver. The machine, after 2 minutes, will say analysing. Take your hands off, don't touch the body. It will analyse and it will tell me whether I need to deliver a shock or whether I need to continue with compressions. If I need to deliver a shock, the orange button will flash and it will say administer shock. I then press the button, delivers the shock, and it will then say analysing. As it's analysing, it will then tell me whether I need another shock or whether I need to continue with compressions. If I need to continue with compressions, locate your triangular bone, 2 fingers above, fingers together, lock arms, and you deliver 100 to 120 compressions per minute for 2 minutes, meaning that you will deliver 200 to 240 compressions. 1, 2, 3, 4. And you continue for the 2 minutes at 120 to 240 for that 2 minutes until the machine kicks in again and says analysing. Now, one of the things that people are worried about when they're delivering compressions is breaking a rib. Quite simply, if you break a rib, they're not going to feel it, they're dead. So you're better breaking a rib and applying proper pressure. So you're going to go 1, 2, 3, 4, and it's quite hard. You have to push down hard. The sound of a rib breaking isn't very nice, okay? But there is no court in the land that is going to allow the person you've just saved to sue you, okay? Better a broken rib than they're 6 feet under, okay? And we don't deliver mouth to mouth anymore either. Other than that, you keep going with your 120 to 240 per 2 minutes with your defib on until the ambulance turns up.
Well done. You are at the end of this presentation. It is a long presentation because we had an awful lot to cover. So well done. If you need to visit the slides again or you're unsure of something, please make sure that you go back over it. If you have any questions, please email us at info@ttr.training.co.uk. Or you can go into our online community where any of the other practitioners will be more than willing to help you. But if it is something that you don't want to discuss in public on in our online group, then please message us either via email or private WhatsApp myself.